It's such an interesting topic. It's for everyone, right? Like oromotor exercises, everyone is doing them in clinical practice.
Everyone is using it.
The big question, do we actually know what we are doing?
So that's what we want to find out.
Hi, everyone. Welcome to our very first episode on our new podcast, Dysphagia Matters, evidence-based talk with me, Julia.
And Jule, hi.
We are not only excited to launch this podcast, but we are also really happy to welcome our first great guest on the show, Ivy Cheng.
Dr. Ivy Cheng is a clinician scientist currently serving as a board member of the European Society of Swallowing Disorders, ESSD. She has a background as a speech therapist and is specialized in the areas of swallowing neurophysiology and swallowing disorders. She completed her PhD at the University of Hong Kong in 2018 and furthered her research through working as a postdoctoral research associate at the University of Manchester in the United Kingdom. Her main research interests include neurocontrol mechanisms of swallowing and the role of neuroplasticity in dysphagia rehabilitation. She has special interest in neurorehabilitation for stroke, Parkinson's disease, and elderly patients using non-invasive brain stimulation and peripheral neurostimulation techniques. Ivy is dedicated to facilitating evidence-based practice through evidence synthesis. She has authored many peer-reviewed publications and book chapters and is a regular reviewer for international peer-reviewed journals. We were lucky enough to get to know her and her expertise at the ESSD Congress 2021 and during one of my postgraduate courses at Trinity College Dublin. This is where we got to hear her talk about neurostimulation and pharmacological interventions, which was very impressive. So welcome, Ivy. It's such a great pleasure to have you on today's episode.
Thank you very much for inviting me to this very exciting new podcast. It's really my honor to be the first guest ever.
Yeah, thanks so much for coming on the show and for agreeing to talk about your research. The study we have chosen for discussion today, and also one of many reasons why we invited you, Ivy, has been conducted by you and your colleagues, Ayodele Sasabon and Shaheen Hamdi, and it was only recently published in October 2021.
Before we dive into this topic, we would like to give you some quick but important information on the paper that we will discuss. It's a systematic review and meta-analysis of the effects of intraoral treatments for neurogenic oropharyngeal dysphagia. Only randomized controlled trials, or short RCTs, were included. In these, mostly patients with dysphagia resulting from stroke and some elderly patients who had neurogenic dysphagia associated with neurological diseases or traumatic brain injury were assessed. Interventions that we studied were oromotor exercises and sensory stimulation. Sensory stimulation interventions consist of thermal tactile, so cold stimulation, or chemical stimulation with the help of citric acid, and electrical stimulation.
Would you mind explaining what exactly you understand by the term intraoral treatments and what does it cover for you?
Yeah, sure. So intraoral treatment refers to treatments that target at or involve muscles or structures within the oral cavity. So that includes the lips, the tongue, jaw, all the way to fossil pillars. And those structures are usually involved in the oral phase of swallowing. So this is what we meant by intraoral treatment for dysphagia.
Great, thanks so much. So could you also maybe explain us what the aims of intraoral treatments in dysphagia therapy in general are?
Yeah, so I think the main aim for intraoral treatment for dysphagia is to improve the swallowing efficiency as well as the swallowing safety. And this can be done by either improving the strength of intraoral muscles, say, for example, the tongue muscles, or by increasing the sensory input to the swallowing neural system through sensory stimulation. So these are the aims of these treatments.
Okay, great. So now you conducted the systematic review and the meta-analysis. Could you maybe tell us a little bit about your intention and the reason why you conducted this research?
Yeah, so the intention is that we've seen a lot of oromotor exercise being introduced in everyday clinical practice. So most notably would be the tongue strengthening exercise or tongue resistant exercise. But we're not quite sure how effective they are for improving the overall swallowing function. Now, considering that the pharyngeal stage of swallowing may be the most central to the whole swallowing process and perhaps the most important phase of swallowing. So we've also seen earlier reviews, systematic reviews, saying that the evidence that support the behavioral exercise for dysphagia are mainly exploratory. So it's not quite certain how effective these behavioral or intraoral treatments are for improving swallowing functions. So we're curious to find out how effective they are. So that's why we're conducting this systematic review and meta-analysis.
In this case, the oromotor exercises are focused on strengthening the muscles, because right now I'm thinking of the debate in the literature between the strength training and the skill training. But now here in your research, you focused more on the strength training of the muscles involved in swallowing and in dysphagia therapy, right?
No, so it's a mixture. So we're focusing on the intraoral tract though. So anything that involves the pharyngeal structures, we did not include in the current review. So
okay.
Yeah, so it doesn't matter if it's strength training or skill training. If it's involving the oral structures, we included them in the review.
Okay, great. Good that we clarified that.
Okay, and what did you actually do then? How did you do it?
So we carried out a systematic review and meta-analysis. So systematic review means that we search through different databases based on a predetermined search criteria with specific search terms. So for example, mouth, jaw, or tongue, that kind of key terms that we do systematic search in different databases. And so the potential studies are then screened for eligibility for further analysis. And this whole process follows a specific guideline from PRISM, and it's done by 2 independent reviewers. So each of us did the literature search and also the screening for eligibility, and then we compare with each other's results, and then we finally come to consensus to see if we've included everything that we think is eligible for the review.
Sometimes it's not that easy to find consensus, isn't it?
Yeah, it is. So if we don't have any consensus among us, so we bring in the third author in. So we discuss and settle in which study to include, which to exclude.
And how many studies did you actually include then in your full text review?
So we included 8 randomized controlled trial study at the end. So the focus of this review is mainly looking at the highest level of evidence, which is the randomized controlled trial studies. So at the end, we included 8 that fits all of our inclusion and exclusion criteria.
But now if we're looking at the broad range of inclusion criteria, so this is quite a little number of RCTs that you found, isn't it? So what kind of studies are these 8 randomized control trials, and what did they look at?
Yeah, so it was a surprise to us as well, because we were expecting much more than only 8 randomized control trial studies. But yeah, for those that fit all of our criteria, including the the patient's characteristics, the outcome measure, and also the design, so the randomized control trial studies. When we are looking at all these criteria, these are the only 8 studies that really fits all of them. And among these 8 studies, we can divide them into 2 groups. One is Oromotor exercise group, and the other one is sensory stimulation group. So 4 of the study looked at Oromotor exercise, and among these Oromotor exercise, 2 of them looked at lip resistance training with a device, and 2 of them looked at tongue training. And for the sensory stimulation group, 3 of them looked at thermal-tactile stimulation, and then 1 looked at electrical stimulation.
Okay, so you have these 8, maybe quite different studies. What did you find out after analyzing?
So we've done the meta-analysis. So what we did was to calculate the effect size for each individual study. And then we calculate a pooled effect size. So we come up with an overall treatment effect for all of the 8 randomized controlled trial studies. And we found that the overall effect was not significant. So the effect we're talking about here is the effect of the treatment compared to sham treatment, meaning placebo or control group, or limited treatment. So essentially, we're looking at only the treatment effects. So we found that the overall effect, it was not significant. And when we separate the two groups.
Sorry, by two groups, you mean oromotor exercises and sensory stimulation, right?
Yes, exactly. Okay. So we separated into two groups, oromotor exercise and sensory stimulation. We found that neither of these groups showed significant overall treatment effect. Another finding that we found is that these studies had really high selection bias, meaning that the randomization is not well documented and also highly biased. And also there are very limited number of RCTs for each of these type of treatments, and they have considerable heterogeneity among them.
Yeah, that is really surprising. You have 8 RCTs in total, and then you can still divide them into two groups, the oromotor exercises and the sensory stimulation, and then you have only 4 each. This is so little research that we have there. That is a little shocking.
Yeah, so especially if you look at like maybe only 2 of them looking at lip training exercise, and then 2 of them looking at tongue exercise. So really it's very, very limited number of RCT that we are analyzing here.
And then in the results section, you state both positive and negative results in regards of sensory stimulation on swallowing have been reported in clinical studies in dysphagic patients. Could you elaborate what positive and what negative effects according to the literature you have found?
So this one is talking about mainly the thermal tactile stimulation. So for the positive effect is that some study reported that there is an improved swallowing reflex in dysphagic patients. So that is from an initial study with 25 dysphagic patients. And this is an uncontrolled study, so only one group of patients.
So it's not a randomized controlled study?
No, not randomized controlled study. So all of them received thermal tactile stimulation, and then 23 of them showed an improved swallowing reflex, so shortened speed of triggering swallowing reflex. But then the negative results, so the negative effect here doesn't mean that they have deteriorated swallowing, but instead it is a neutral or no treatment effect reported by some other studies. So some other studies find any improvement in swallowing reflex, and then there are also not much evidence for long-term after effect for those improvement that was observed initially.
So in this case, the negative effects, they don't mean that there were adverse events that you could do or that they did any harm. It's just that it wasn't effective for treating dysphagia.
Yeah, exactly.
Okay, now looking back, were you surprised by anything?
So I think we are mostly surprised by the fact that even though for many years oromotor exercise have been used in clinical practice, and it's one of the most common rehabilitation treatment options that we offer for patients, but there are only very few RCTs in this area. So I think the major reason for that, for the small amount of RCT, is that the lack of resources. It may not always be feasible to conduct RCTs, especially in clinical settings, because compared to like pharmacological studies, it is not as easy to conduct a RCT with behavioral treatments. And then another reason is perhaps the lack of funding to look at something that is already used in clinical practice, compared to looking at something new and novel and exciting. So it might be a lot harder to get funding to do research in these areas concerning the existing clinical practice or clinical treatments.
So do you think we missed the time where we could have had more funding for those kind of therapy, and now we are all like into the technology and we're all like excited about it, and now those basic treatment options, they're not looked at that much anymore, and it's harder to get funding. Do you think that might be a problem?
Well, so all these kind of treatment, they had support from exploratory studies. So for example, study that was done in healthy volunteers, or some studies that were looking at only one group of patients, but not a randomized controlled trials. So there are several previous research that have been done in this area. I think the trend right now, like the recent development right now, is to we tend to develop a more well-designed treatment protocol, instead of saying, we're doing ton exercise, but we would also want to look at how intense we are doing this ton exercise, how exactly we're doing it with device or without device. So I think in principle, we're still looking at a prime time to look at this kind of behavioral treatment. We can shift the focus to develop something more systematic and more well-documented treatment protocol.
It doesn't really mean that we're not doing the research anymore, but we're focusing on doing it better in terms of the quality, like how we design the study protocol, how we conduct the study. So that probably makes it even more complicated, right? Because we're not choosing the easy way, but the high quality way, so to say. But still, yeah, we need to do it, right?
You've just started to talk a little bit about exploratory studies. Do you mind maybe explaining again what exploratory studies are and why this is a problem for providing clinical recommendations?
When we talk about the level of evidence of different clinical studies, there is a pyramid of evidence, if you could recall. So at the base of the pyramid is consensus or expert opinion, that kind of paper or article. And then slightly higher level of evidence is those unfiltered studies, meaning that unfiltered information, meaning that exploratory studies, like studies that is done in healthy volunteers, or case report, or some case series, and or some non-controlled studies. So only one group without any randomization, without a control comparison group. So these are what we call the exploratory studies. The problem with relying on exploratory study is that we may not be able to see the full picture of how effective the treatment is. So usually we consider randomized controlled trial study are the highest level of evidence, because in a proper RCT, which is short form for randomized controlled trial studies, you have two groups at least. So one comparison group, which is usually a non-active, no treatment group. And then another one is the group that is under studied. So that is treatment under studies. Another important element of RCT is that you randomize the people that are receiving each of these treatments without any bias. So that is considered the highest level of standard in conducting clinical trials. It's only with all this randomization and also comparator, then you can find out how effective a treatment is in for that particular group of patients.
Thank you, Ivy, for your great explanation. You can find more information in the show notes of this episode. We might record some future episodes on different research methods, study designs, and aspects like biases. Let us know in the comments if you'd be interested in any of these topics and if you would like us to record an episode about it. So, what clinical implications can we now draw from your results? What does this exactly mean for clinical practice if intraoral treatments don't have beneficial effects on neurogenic dysphagia?
Well, at the moment, at least from our results, there are not enough evidence to support the clinical efficacies for these intraoral treatments. Now, we're not saying that these treatments are absolutely have no potential in treating dysphagia. No, that's not our intention. So what we want to tell the reader is that you need to be really critical when you are choosing the treatment for your patient. For instance, if you were to choose intraoral treatment for dysphagia, then you need to read carefully what kind of evidence there is in the literature. So we found in this review that there are not enough evidence, but there are several other exploratory studies that might support the use of these kind of treatments. So usually when you're deciding if you want to use this treatment for certain type of patient, so you need to look at all kinds of evidence. So for example, is there any evidence from healthy volunteers looking at the physiological effect of those exercise or treatments that you intended to use? So for example, some studies have shown that tongue strengthening exercise can induce neuroplasticity in humans. In healthy volunteers, though, these may give you some hints that these kind of treatments may have the potential to be beneficial for these dysphagic patients. I believe that with larger number of RCTs in the future and with bigger sample size, then we can see that this level of evidence that we see now can be changed.
So you do see hope?
Yeah, I do see hope in this area. We just need more good quality and large-scale RCT.
Yeah, so that was actually another question I had for you, because I was wondering, like you have already said, what we need in the future, so better or higher quality RCTs, so that we might be able to implement intraoral treatments in dysphagia therapy that are based on evidence. So another thought that I had was maybe in 30 years from now, we'll all be like, how could we have possibly implemented oromotor exercises and sensory stimulation in dysphagia therapy at all? Do you think that might be the case, or are you more the positive person here and saying, no, we will get that research and someday we know how to implement it, what the protocol should look like, and for which patient we can choose which type of exercise?
Yeah, I think I tend to be a little more optimistic here.
That's good.
Yeah. That's my opinion. I think with better study design, better control for bias, for example, selection bias and personal or blinding bias, good quality RCTs, I think then we can come up with better evidence for these kind of treatments. But right now, we really need to do more research in this area before we can conclude that this is so effective for neurogenic dysphagia.
I'm so glad that you're optimistic. Because I also, while reading your review, I thought of one of my patients. She's a lady in her mid-80s and has an oropharyngeal dysphagia resulting from a stroke and presents with impacts on both oromotor and sensory functions. She lives in a nursing home where I see her once a week for treatment. And I think she's quite a typical patient for the setting. And I guess many listeners might have similar patients on their workload as well. So I know it's a very big question, but can you give me and other SLTs with these classic patients some recommendations on how to treat their neurogenic dysphagia?
Yeah, this is indeed a very common kind of patient that we can come across during our clinical practice. While I cannot give you a specific recommendation as to which treatment is the best for this kind of patient, then what I can tell you is the main takeaway of this review that we've done is that when you're choosing which treatment to use, you should always look for all kind of studies instead of just one. So instead of only looking at one study saying that it is effective and then you use it in with the patients, you should better look at all different sides of evidence. So if you could find systematic review, then that's great, because it's usually the has done the work for you in analyzing different evidence. But be careful that each systematic review has different inclusion and exclusion criteria, so they may not fit the target that you're looking for. But if you can't find any systematic review for that particular treatment, the best you can do is to look at all the randomized controlled trial study evidence. if there is no RCT at all, that you can't find anything in the literature about the treatment that you want to use, then look for some exploratory studies. Is there any evidence showing that it works in healthy volunteers? Is there any, for example, neurological evidence saying that these treatment can bring about some long-term neurological changes? That's how you can design which treatment that you want to offer for the patients.
Yeah, thank you. Some good tips for the path on deciding which treatment to choose. Because I have to say, when I was reading your review, I was a bit, depressed is maybe too strong, but working in the setting, going to a nursing home or to patients at home, I don't have access to maybe treatment options that have more or a better quality evidence. So I was wondering on what would the alternative be on intraoral treatments that I could implement now?
I think it would also depend on the kind of patient that you're seeing, like what kind of specific deficits that they have. So is that mainly oral phase deficits, or does that involve pharyngeal phase deficits as well? So that would also affect your decision. And if it is involving more of like pharyngeal phase difficulties, then the intraoral treatment may not be useful for them at all. So so I guess it really comes down to what that specific problem that patient has.
And in this case, we have another problem, or maybe another barrier that we might come across. Like if we're in a nursing home, we might not have access to FEES or video fluoroscopy, and then we can't really tell by our clinical swallowing evaluation if the patient actually has a pharyngeal problem or maybe even esophageal. So yeah, that makes it so complicated, and we are so glad that you did this systematic review to show us, or all the readers, that something that we've been doing for so many years, maybe not us, but because we're still a little younger and we haven't been working for that long, but what we have learned. So it's such a basic fundamental approach for us in dysphagia therapy, but it's so surprising that there's not enough evidence so far. So thank you so much for your opinion and insights.
Thank you very much for having me here and talk about the paper.
Do you have anything to add, or did you forget to talk about any important aspects? Maybe any positive thoughts for the listeners, so we don't have such a pessimistic conclusion?
I think one thing is that when you're looking at the paper that we've written, we are only really focusing at the intraoral treatment. Those studies that looked at swallowing maneuvers or anything that involves pharyngeal structures, we did not look at those. So it is possible that other behavioral treatments that involve these structures has better evidence than intraoral treatments. I know that recently there is another systematic review that's published looking at all different kinds of behavioral treatments for dysphagia, and the results is quite promising, actually.
The systematic review we're talking about here is entitled Behavioral Interventions in People with Oropharyngeal Dysphagia, a systematic review and meta-analysis of randomized clinical trials, and was written by Spire and colleagues, published in January 2022. You can find the link to the article in the show notes.
So if you're interested, you can really just look at all these different kinds of systematic review with an open mind, and bear in mind that different systematic review has different criteria. So you need to pick one that fits your purpose most when you're designing which treatment to use.
Yes, that's so true. And thanks for that great advice. That actually reminds me of another paper that was just recently published by Antonio Schindler and many other colleagues on the treatment of dysphagia and Parkinson's disease. And what they say is that we do have several options for treating oropharyngeal dysphagia in this population group, but we are still lacking a consensus on their efficacy. So what they did is that they conducted a systematic review of the literature first, and not really surprising, they found a generally low level quality of evidence. So based on the available evidence, they phrased statements, and through a Delphi method, they aimed at achieving consensus on those statements. So in the end, these statements are basically their recommendations for diagnosing and treating dysphagia in people with Parkinson's disease are based on the literature and expert opinions. So this includes a level of the evidence from the very bottom of the pyramid. But due to the lack of high quality research, the expert opinion in this case is really valuable. We will link the article in the show notes as well, and I can highly recommend having a look at it if you're interested in Parkinson's disease and dysphagia.
Yeah, exactly.
Yeah, great. Thanks so much.
Yeah, thank you, Ivy. Like we said in the beginning, you and your work are really inspiring. We hope to hear and read a lot more from you and hopefully see you again soon.
Thank you very much for inviting me.
Thanks so much, Ivy. We really appreciate it. We hope you, our listeners, enjoyed this episode as well. If you would like to get in touch with us, follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or send us an email at hello@dysphagiamatters.org. Thanks so much for listening. Thank you, Ivy, for coming on the show, and take care, everyone. Bye.
Bye.